Hi, welcome to the 4th annual UHS Runway Lecture. I'm Louise Greenspan, and I wear a few hats at university right now. I'm the parent of a sophomore, Ella Barrett. I'm a trustee, and I'm a proud alumna of the UHS class of '86. Our topic of advancing public health equity in the time of COVID-19 is of special interest to me because I'm also a physician. I'm a pediatric endocrinologist and clinical researcher at Kaiser Permanente based in San Francisco, where I treat and see the consequences of health inequities firsthand. And I'm exceptionally proud of my fellow alumni in today's panel, who you will meet shortly. Runway is designed to bring the energy and dialogue around social justice, equity, and inclusion to our campus directly, that's on our campus directly to the adult members of our community, providing you with runways to be change makers yourselves at work, as volunteers, and at home with friends and family. Runway was founded in 2017 and in the past has been held as a really fun luncheon at the Downtown Olympic Club, free to attendees who work in social justice professionally. Runway is sponsored by the UHS Alumni Association. Today on Zoom, we have students, alumni, parents of students, parents of alumni, grandparents, current and past faculty. I see a lot of my old teachers, friends, and members of the public with us. For those of you who may not be familiar with UHS, here at university, we embrace education as a transformational experience, empowering our students to invent and sustain their own vision of success and sense of purpose, while also prioritizing wellness and self-care. They in turn grow into motivated learners and creators excited to make their mark on the world. We believe that collaboration amongst people of diverse backgrounds and life experience is essential to deep learning, and we challenge our community to engage in learning, reflection, and growth on all levels, not just in the 4 years of high school, but for a lifetime. Years ago, our Dean of Faculty, Nassif Iskander, wrote a textbook to use in his upper division physics class called Oceans of Truth, essentially the history of the study of physics. Physics is now a required foundational course for all 9th graders, and the textbook has proved to be an invaluable tool, introducing right brains to the discipline through narrative storytelling and ensuring that left brains keep in mind that science doesn't only happen in a lab. When the textbook was published on iBooks in 2017, Nassif wrote in the foreword, although observation and experiment are an essential part of the scientific process, culture, politics, and the availability of resources play a huge role, even in determining what questions can be asked. Common sense lies at the heart of our ability to interpret what we see, but notions of what is reasonable and sensible have changed dramatically throughout history, and certainly throughout this past year. This fall, our librarian, Nicole Hunter, is teaching healthcare justice as part of the 11th grade social issues curriculum, and her students will study today's remarks in their class. Nicole wrote in her class description, as we weather the COVID-19 pandemic, the stress on our healthcare system has never been greater. In a time where equitable access to healthcare is essential, our system is revealing long-standing and grave disparities in access to care and in health outcomes for people of color and vulnerable populations such as the elderly and homeless. Indeed, what a timely discussion we're having today. Our moderator, Jennifer Rogers from the class of 1991, will introduce you to our alumni panelists shortly. But I do want to take a quick moment to say that we are especially proud that Dr. Jeffrey Hom, class of 2000, is available to join us. Jeff is one of the recipients of the 2020 Alumni Honors, our Distinguished Alumnus Award program. Our other panelists are equally as distinguished and wear many hats among the 4 of them: public health official, gerontologist, pediatrician, nurse, foster care health provider, author, addictions expert, community organizer, and advocate for the unhoused. Now I'll turn it over to Jen, who is an award-winning anchor and financial reporter for Yahoo Finance. Thanks, Jen.
Thank you so much. And I am thrilled to be here. As you said, we have just an incredible lineup. I could spend the next hour just going over the work that they have done. If you are curious to see their official biographies, you can head over to sfuhs.org/runway lecture. But let's dive into the topic at hand right now. And as we all, imagine you're at the Olympic Club at the lovely lunch. You're in your office right now. I'm in my house where I work. We all know that 2020 has changed so much for us. The US has just recorded its worst week yet for coronavirus cases, a record 500,000 new cases in the past week. On the upside, we have not seen a surge in reported deaths, but nearly 230,000 Americans have died. It has changed a lot for us, and it has brought the health disparities that really have always been there, but to the forefront. And I want to dive into just the topic with all four of you right away about how 2020 has changed the work that you do. And Cynthia Brown is the lucky one because we are from the same class. Woohoo! 1991. Best point guard there ever was from UHS. So we're going to start over with Cindy. So just a little bit on her. She went to Yale School of Nursing, then spent 18 years working as an advanced practice nurse in pediatric primary care and hospice. Deep work with the foster care system professionally and as a foster parent herself. And right now, she's an administrator at a large public health center in East King County in Washington State. So what has 2020 changed for you? I can't, you've been on the front lines these past few months. Tell us about it.
Yeah, it's amazing. I actually joined public health in February this year. So before that, I was working directly with the homeless. So I guess 2020 put me back in healthcare for sure. And it wouldn't have been right if I didn't come back into a pandemic pretty much. Changed the way we work. I mean, we had to close down services. We had to go to virtual care. We had to go to phone visits. So it really sort of ended how we perform our services, especially for the most vulnerable who need to come to clinic, who don't have phone minutes to talk to us, who don't have web capability. So we had to be agile and make some of our services mobile to get out to reach who need us the most.
And are you more optimistic right now or less optimistic than, at the beginning of the pandemic in terms of the community that you're serving?
I think I'm certainly concerned about the community I'm serving because a lot of the people that I serve are undocumented, and so they're not getting a lot of any services that are supposed to help those who are low income anyway. And our clinic is pretty far from where they live, so even just getting here is a struggle. So I'm hoping that they can find care where they live, because I'm less optimistic right now. I know that we're going to provide great care regardless, but I'm not sure what's going to happen above us, the people who fund our care, because we're bleeding. We're bleeding resources right now.
I want to head to the other side of the country right now. Let's bring in Dr. Jeffrey Hom. He's a policy advisor in the Philadelphia Department of Public Health, a board certified internist, and his current focus is on substance use, particularly issues around access to treatment and harm reduction. So Dr. Hom, the same question to you on what 2020 has changed for your work.
Yeah, thank you, Jen. And thank you for the chance to be part of this panel. The work certainly has changed. For me personally, I think it's been taking on new responsibilities. Our health department, like every other one across the country, pivoted almost entirely to respond to COVID-19. And that meant many of us taking on new roles. And so while most of my focus has been on sort of substance use and harm reduction, since our pandemic, I've been our liaison to our city's COVID surge hospital and now provide sort of medical guidance to our isolation and quarantine site. But I think more importantly, when I sort of step back and think about what this year has changed for my work and my division, focusing on substance use, it's been a big year, and specifically as it relates to this Runway Lecture. Everything from COVID to Black Lives Matter has really not only brought to the fore many of the inequities that we've been grappling with in the substance use field, but I think it also gave us a new mandate to really try to address them, because different racial and ethnic groups haven't been treated equally when it comes to drug use and treatment and criminalization. So this year we've really broadened our scope to not only address, I think, the consequences of drug use, but also look at the structural factors that drive our overdose crisis in certain populations. And then two, ensure that our interventions are developed through a lens of health equity.
And just to follow up there, given that you have had to concentrate on COVID, and react there. Are you concerned, as we've been hearing about, more people abusing drugs or issues around depression and suicide as it relates specifically to being isolated or being stressed out because you don't have a job? Are you worried that your work is going to be even harder on the other end of this?
Yeah, absolutely. Thank you for bringing that up. I mean, I think just like you said, the trauma that a lot of folks are experiencing now, the depression, the anxiety, the uncertainty that lies ahead, we have sort of seen in some of the data that there has been an increase in individuals who are using alcohol or turning to other substances. That they may be turning to cope, to sort of self-medicate some of these challenges that they're facing, and we're worried about that. And then I think we're also worried about just sort of the messaging that, for the last several years, our messaging around substance use has been, use with somebody, use in smaller doses, so that in case you have an overdose, someone's there. And now we're also telling people, but also stay separate, stay by yourself, stay indoors. And that counter messaging is very difficult from a public health view. And then lastly, I think just to your point about thinking about the role of employment and unemployment and what that can also do to the risk of using drugs and potentially overdosing.
So I want to bring in Dr. Thomas Magaña. He is a board-certified pediatrician with expertise in the care of vulnerable youth populations, including those impacted by the juvenile justice and foster care systems, immigration also part of it, community violence also part of it. So tell us what these, first, gosh, I wanted to say like 6 months, but it's November tomorrow. So what the bulk of this year has been like for you?
Well, first of all, I just want to acknowledge all of some of these familiar faces who I haven't seen since I was 17 years old. So time, which was only 10 years ago, of course. But it's lovely to see that and to be part of this panel. Thank you for asking that question. I think the better question would be, well, what has it changed or pivoted in this professional world of ours? And I think, the other panelists have kind of articulated how it's changed the way we do medicine and the way we practice. I mean, we had to do in my clinic, and I work in a safety net health center, one of the largest in the East Bay. We had to immediately pivot, right, from a continuity-based clinic now to a telephonic telemedicine format, which had its own challenges. We were not equipped or set to do that. And so it not only disrupted continuity of care for some of the most vulnerable people in our community, but the organization took a significant hit. We have to acknowledge the financial impact this pandemic has done on some of the primary safety nets in our community, many of which are struggling right now because the productivity numbers have gone down and the way, reimbursements are done. So it's not just the individual care, which we have to maintain at high quality, but it's also sustaining organizations, which have been the primary security nets for some of the most vulnerable. This pandemic has simply just highlighted, disparities which was suggested before that were well existing, previously. It's just magnified and amplified so many of those challenges. But in my other world, I work very directly in education, and I work across the pipeline with high school kids up to graduate students. And in every possible way, our ability to educate students has changed as well. With school closures, shifting to an online format for young people has been an extraordinary challenge. And if you think of that in terms of healthcare preparation, which is what I do in all of those areas, we have to pivot and innovate very quickly to ensure that quality of education hasn't been threatened in any way too. And that's been extraordinarily challenging as well, just in terms of pedagogy and creating curriculum that is responsive to student needs and to educational needs, but also to understand that there's a huge divide in terms of access to technology, particularly the populations I work with. And so many students have not had the type of access that they had previously when they would go to school. And more than that, the challenge of keeping them engaged on a regular basis is an ongoing challenge. And with regard to the anxiety and the depression, we have absolutely seen an increase in adolescents and in young people. The acuity of that has significantly increased. And what that means is that then it has highlighted the major gaps we have in terms of our behavioral health workforce, and our ability to refer and to ensure that those new behavioral health needs are met. So, I mean, it's very complex and it's very complicated.
We keep in the business world that we're going through these changes, but these changes are going to stick around. So you're shopping online, you're going to just keep shopping online. You're riding your Peloton, you're just going to keep, we've just accelerated these changes. So when you talk about some of the things that you're seeing in underserved populations and youth, are you worried that some of those are going to stick around as well? The depression and the lack of access to resources, that those aren't going away anytime soon?
Well, that's again a complicated question. I think we're going to see an immediate acuity because this is kind of the immediate response to a very unexpected threat and has kind of changed our world upside down, and any sense of normalcy is now backwards. Things are beginning to level off as people are beginning to adapt and adjust. And I think the benefit, if we want to look at the positive side of all of this, is, as I think what's been highlighted before, it is actually forcing us to be innovative and to think outside the box in terms of our care. So in terms of thinking of a hopeful lens, I hope that those innovations, right, and that forced necessity to pivot will actually improve care in many ways. But I think the legacy of this is going to be around for a while, because the social determinants which have created these disparities in the first place are not changing, and not anytime soon. And in fact, as I said, they're getting worse as a result of this pandemic. So we're going to have to deal with this for some time.
Let's take that hopeful lens and go over to Dr. Louise Aronson. She is a geriatrician, a writer, educator, professor of medicine at the University of California, San Francisco. She is also the author of the best-selling book, Elderhood. It was a Pulitzer Prize finalist and a regular contributor to the New York Times and the New England Journal of Medicine. So, you know, I think of the population that you are serving and how it relates to COVID. I mean, we all know what the numbers look like with the older population. So talk to us about what 2020 has been like for you.
Well, I just have to echo what everybody else is, like everything changed, absolutely everything. I'm in clinic today. I decided to live on the wild side and take off my face shield so that I could see all of you. You can see me slightly better, but I apologize for the mask. Well, so clinic went virtual initially for many months. Now that's a problem for a variety of populations. The people most likely to be across the digital divide are poorer people, people of color, according to some studies. There's a little bit of overlap between poverty and people of color. So speaking of anti-racism movements, et cetera. Also older people, and the rates of digital low literacy go up with each decade of life. By definition, no one who is in elderhood can be a digital native. You know, and I don't know if anybody saw, but there was an article in the New York Times maybe 5 years ago, and it talked about how compared to 5-year-olds, 11-year-olds were digitally inept. So if that's the case, the rest of us are in deep trouble. So yeah, so teaching went online and we had to learn how to manage people, and in terms of inequities, where people live. So you usually want to see your learner, but we made a decision as an institution to allow people to have their video off if where they were living was a place they didn't want the whole world to know about. For clinic patients, I have some patients who can do that and some who can't, and reimbursement is much bigger for video. So health systems are wanting video, you know, in person if you can do it, but it doesn't really allow for the fact that then you're paying the least amount of money to a system that's doing its best to work with the people who are by definition more vulnerable, which is why you're talking to them on the phone. And it's going to be harder to assess them because you're on the telephone with them. You can't actually see them. Not that, you know, yesterday I had a 93-year-old in heart failure via video, and, you know, my stethoscope, which I have today in clinic, was of no use whatsoever. So there's all of that. There's also the fact that shelter-in-place orders are very much in place for older people. And it leads to a couple of things. One, because of internalized ageism, people who feel they're fit just go out and take risks when we know the death and severe illness curves go up. Actually, starting in your 50s, I'm sorry to those in my class and those near me, it gets much worse thereafter, you know, with each subsequent decade, but we're already in trouble. And then the people in long-term care settings, which I just have to add in my little PR moment. When I ask younger people what percentage of older adults they think that is, the most common answer is 70%. So for nursing homes, it's 1 to 2% of older people, and you can add another few percentage with assisted living. But those are people who basically have been, as one of my colleagues said, incarcerated without judicial review, as we decide that the only way to take care of other people is to lock them up and deprive them of all human contact and services. I could go on and on. I will just echo on a more positive note what Tomás said, which is actually something I'm quoting one of my students, Derek Paul, who said, you know, I used to think it would be so hard and it would take my whole career to change the health system. And then in early March, in 2 weeks, I saw everything change, what each building was used for, what each person did, what we wore to work, who we saw at work. So now we know they can do it, which means every time they're not doing it, they're choosing not to do it.
That's a really interesting way to look at it. Tomás is saying he's agreeing with you there.
Yeah, well, he led that one off. I was just giving it the second punch there.
He's agreeing with you. You know, before, I want to stick with you, and I actually want to go to a question from a student from Nicole Hunter's class, because you brought up ageism, and a lot of 2020 has been talking about the intersectionality of different issues. And I wanted to talk about, you've got ageism, but we also have systemic racism. And has that shown itself in your daily life there, in your practice, in the hospital? Has COVID-19 made that at all more noticeable?
Oh, yes, in so many different ways. So we know, for example, this is news to many in healthcare and also in the media. So you'll hear highest risk, old people, highest risk, people of color, and, you know, on the West Coast, Latinx populations. It's almost as if it hasn't occurred to them that you can be both these things simultaneously. And that is where we're seeing the highest risk points. If you are an African-American woman in long-term care, your chances of getting COVID and dying are astronomically higher than anyone else. So there's definitely interrelationships. There are also interrelationships at the community level, because taking care of older adults becomes so hard that we outsource it, right? So we end up putting people's loved ones into facilities. So this is such hard work that people decide not to do it for the people they love best. And then we pay minimum wage, which in San Francisco, let's be clear, is not a living wage, to the people who do that work that is so hard and so important. Those people are at hugely high risk, and most of them need to take public transit and need to live in congregate settings themselves. So we had an outbreak at one facility, and it turned out a guy was coming to work and going back and forth, and he hadn't told anyone where he lived because he lived with 17 other people in Daly City. And that was the only way he could afford any rent in this environment. And so if he told them he had COVID, he was going to be kicked out. And he was in Daly City, not in San Francisco. In San Francisco, we have some INQ, and he didn't really know there were options there, and he was afraid of losing his job. So there's so many ways in which this is really intersecting. And then, you know, as I was talking about earlier about the digital divide, my most underserved, disenfranchised patients are the ones least likely to, have access to broadband. I mean, here we are by Silicon Valley, where there are so many, being a millionaire is like old news, right? So why do we not have universal broadband? Et cetera. So it's pretty tough. And at UCSF, they were trying to make it more accessible. So a lot of people were working on this. And I went on one of the calls, and this very well-meaning young man was answering somebody's question. He said, will you just tell the person to go stand by their router? So in my practice, and for the average person over age 70 or 80, let's say, nobody knows what a router is, and they don't know where it is, and somebody else put the internet in, and that's just not helpful, and it doesn't really occur to people. I would also say on a societal level, if any other segment of the population accounted for 80% of deaths, that segment of the population would have access to testing, which has not happened. They would have access to N95 masks, which has not happened. and they would not be locked up and told not to come out and told the people for, those people who need some support, their supports not to come. They would not be, although actually a colleague of mine in Canada tweeted out something, if it were children in boarding schools, we wouldn't lock them away from their families for 7 months. And then he had a line break. And then he said, unless of course they were disabled children. So there is a way in which ageism is more acceptable. And there's an innings played ethical approach, which says, well, if you've had 80 years, then we should of course value the person who's only had 8 or 48. And that can be true in a zero-sum game. You also don't want to judge the value of a particular life. Like, for example, President Trump got all kinds of treatments that probably were responsible. There was just a publication today or yesterday about one of the cocktails he received, and it really does decrease the severity of illness. Most people aren't getting that. They also get tested daily. And there are these huge differences in who we're prioritizing and where we are putting resources. We are a very rich country. We could have enough masks and enough testing if we had enough leadership and a coordinated response.
I just want to give credit to the student that asked the question, since I didn't say the name before, Ria Dillon. And we also have one that's kind of similar from Jenna Kumar here. And I want to head back and get the rest of the panel to kind of be able to chime in about some of the issues there that Dr. Aronson was talking about. So let's go back to Cynthia Brown. So again, Ria Dillon and Jenna Kumar, they're talking about, and they're students again in Nicole Hunter's class, about systemic racism that you guys are seeing on the front lines. And Dennis' question is, how effectively are the statistics related to these inequalities communicated to the general public? And in what ways can the information be spread to larger audiences? So Cynthia, do you think that there is a question about some of the issues that we've been talking about, but getting the information about the inequity spread out there? Or do we know enough about the information and we need to be concentrating on other issues here in terms of equity?
I think that we have a lot of information, but the people who need it the most probably can't get it, or what they can get is distorted by social media, or they're hearing the wrong messages. So they're in a hard place of trying to get those messages out there. I mean, I think we had a lot of unrest in the Seattle area with a lot of protests and that kind of thing going on. I don't think my patient population was aware of what the underlying issues were. A lot of my patients are Latinx, and that Black Lives Matter issue didn't resonate for them. We're not connecting the dots. That this is a global issue for everybody. So, and a lot of my staff have that same mindset because public health has declared racism a public health emergency, and they're telling us to do certain things here. And I'm looking, I was like, my staff is mostly Latinx and East African. They're not connecting the dots too. So like connecting those people is what we need to focus on, I think. Because the inequities are there. I mean, we see it in who we take care of. We see it in the resources that we have in this public health center versus, other center.
Dr. Hom, you were just nodding. So I'll go to you on this and then to Tomás as well. And, I think you responded as well to what Dr. Aronson was saying.
I would just agree with what Cynthia just was sort of talking about in terms of how we communicate data to the public. I think particularly around inequities, I think our quality of information that we distribute really sort of varies. I think sometimes we communicate disparities very clearly and effectively. So I think, for example, when we talk about some of the social determinants of health, we talk about how zip codes correlate with life expectancy more than other factors. That someone growing up in Pacific Heights is likely to live 10 years longer than someone living south of Market. And something clear like that, I think, can make people sit up and take notice. But there are other statistics that are much more nuanced and don't translate well to sort of like the newspaper headlines. And I think that's a little bit on us as public health departments and public health professionals to be good about distilling information and communicating it publicly, because we do have, like Cynthia was talking about, we do have a lot of data, and it's making sure that we're able to get that in a meaningful way. And I think that's especially important now when there's so much information out there, and it's trying to counteract some of the misinformation that I think is also out there. that does put additional sort of pressure on us to sort of be constantly pushing information out there, but to be cognizant that we need to do it in the right way and in the right format where most people can really absorb it. And in particular, those who need to hear it, who may be less connected to sources of information, we need to make, prioritize and concentrate our efforts really to reach those populations.
And Dr. Magaña, I want to go to you on this and give it a little bit of a different spin with a question from two students, Maricel Tao and Janine Navalta, who is still in the same space that we're talking about, but because you work with a lot of students and on education as well, and they're interested in how students can get involved with helping to fight for equality in the healthcare system, especially during the pandemic. So that, the issues that we're talking about right now, what can somebody that's in high school do?
That's a great question, and I appreciate that young people are beginning to ask that. And I think that is reflective, I think, of this generation at large, is that they are attuned to what is going on to this world. They are certainly more connected through social media platforms and that which is going on, far different than those in my generation, where I'm still trying to catch up. And I think it's kind of along the lines of how we would build a trauma-informed system, right? The first thing of that is you have to recognize that these inequities and these challenges exist. And then you have to understand within the context of how those are relevant, because we're talking a lot about data and we're talking a lot about the statistical information, and our communities of color are aware of this, and how is that relevant? We have to remember, communities of color, this is their daily reality. It is not just a simple issue of fact and statistic. This is their reality in terms of living and surviving within the context of disparity on a daily basis. We have Latinx communities that are not just dealing with the fact that they are some of the hardest hit, but this is coming off also a history of ICE raids, of which some were done directly on my clinic, as well as the threat of detention centers and all of that, which have been going on. So this is a cumulative impact, one right after the other, that has profound kind of emotional and mental implications of this, number one. So recognition and acknowledgement of that is really, really important. And then kind of an inventory of self-awareness, and what role we contribute to that notion, right? And the perpetuation of racism and disparity through consciously or unconsciously, and how we act, what we choose to do, who we vote for, so on and so forth. But I also think, a big part of the solution is innovation, thinking outside the box, right? Because clearly the traditional systems, public health system, educational systems, healthcare systems have failed to effectively address the challenges that have been perpetuated over the past decades. If nothing more, they've gotten worse, particularly when I think about adolescent health outcomes and so forth. So I think what young people bring is a new spin and a new perspective that has a global perspective and also incorporates this notion of community and connection. And I really, when I work with young people, I tell them that really they hold the solutions to many of the problems that lie ahead, right? And I want their innovation and their thoughts to be part of the dialogue. Yet young people are very rarely included in those dialogues that are happening at higher levels. And so I would like to see systems to include them more, and for young people to advocate for their place at that table.
So Dr. Aronson, in your book, so there's elderhood. So it's like you're young, and then you're old. But I'm in the middle. I guess I have that last chapter. So I want you to speak to students of all ages, right? Because I think even people that are in their working years, they might have another chapter ahead of them that could involve some of the work that we're talking about right now. So to answer the students' questions about what they can do, but I think it's really like what everybody can do right now to address some of the issues that you are seeing up front.
Right, I think that's a great question. So just to clarify about elderhood, so there's childhood, lasts about 20 years, kind of depends on the kid. Certainly in my family, I know that's the case, but then we have adulthood that goes for another, 40, 50 years. And there, the difference, the tipping point between adulthood and elderhood has a lot to do with social advantage and disadvantage. The people of color or the poorer people in my practice are more likely to be what people think of as old and have diseases of aging a decade or more earlier. And that's also that cumulative trauma that Cynthia and Tomás were also talking about, when every day is stressful and every day you are a suspect as you do something as simple as go to the grocery store. And then there's elderhood, which for many people now lasts longer than childhood. We have so often sort of pushed elderhood into, or the word old, into the final years of frailty, and that is absolutely one of the phases of elderhood. But if it starts at 60 or 70, then a lot of the people at the table are actually people already in elderhood. So Tomás's point about the teenagers, they're more likely to be missing than the younger elders. How do we all do it? I think it really has to do with advocacy. There's a group called Race Forward that has really shown that the squeaky wheel tends to get the institutional support, and people of greater privilege are more likely to squeak, just to sort of use that in a particular way. And so you really need to collect different sorts of data. And you need to tell stories. So one of my other roles is really helping give people from usually our medical students, but also, you know, faculty and patients, the tools with which to tell the stories that humanize people who are different from the people in charge or just the people around them, so that they can see the shared humanity. So I do think it's important that we get people's stories and help them to tell them themselves. There is also a tendency, there's something in geriatrics we call learned dependence, which is, you're old, I'll do that for you because I do it more quickly. And young people get it all the time, like, you're young, you don't know about that, I'm going to decide for you. So it happens in different ways across the lifespan, and to recognize that these are all the same human problems, and to work on connections, because we know that the younger generations of teens and 20s, despite all their social media connectivity, were having an epidemic of loneliness and isolation. That's also huge in older years, although for different reasons: friends, siblings, partners dying. Sometimes it's geographic or physical isolation. So I really think of the innovation about the connections and about demanding what's right. We actually don't have a healthcare system. What we have is a medical care system. We want to do procedures on you. We want you to be in the hospital. And better yet, if you're in the intensive care, woof, the health system makes way more money and it's so much happier. And if we can prescribe lots of drugs for you, that's terrific. We are not about maintaining your health. And until people start making noises about that and about the lack of universal health insurance, we're still going to be arguing about the wrong things. For my population, people say, well, we can't afford to provide health care for all those old people. Well, actually, we could stop torturing people who, you know, giving them very expensive procedures that are proven not to work. Or when you're dying, not be able to talk about dying and not reward talking about dying in a way where people could live the end of their lives in a good way. We just have to move the money around in more effective ways.
I want to talk some about money, but I also want to invite everybody out there to put some questions in the chat right now that we can look through. Again, we've gotten questions from Nicole Hunter's Health Justice class. Thank you all so much for submitting those. And if more people want to put questions in the chat, we can get to those. On the money front, I want to go to Dr. Hom here. We do have a question from Dr. Leland Rosenblum, a class of '82, an ophthalmologist practicing in Monterey County. And it touches on the financial implications and how we should be thinking about the money we're spending as it relates right now to the US government and their stimulus and the coronavirus relief packages and other packages that have been put out there. So as somebody that's on the front lines and in your own work, how do you, when you're in the health system, I mean, how do you think about valuing money and lives? I mean, how should people, I mean, it's a big question, but how do we try to process this just as individuals when you see these big round numbers and you think, wait, what are we doing? Like, how should we be directing our funds?
Yeah, thanks, Jen. I think that's a good question. It's certainly a big question that I'll do my best to share my thoughts about, and I'm eager to hear my fellow panelists and their opinions on this. I agree that these relief packages are have been extraordinary, and that that we do need to be thinking about the economy, and we need to be thinking about people's well-being and their employment opportunities because of all of the implications that has on health too. But I don't sort of buy into the belief that there's a ceiling above which it's not worth investing in to support both the economy while also implementing robust public health measures. You know, irrespective of the cost calculated per death or per life saved, you know, it's just that, you know, other models, you know, for example, like the herd immunity, you know, approach that some people have talked about, Sweden's approach of not doing particularly anything in particular, you know, does risk doing tremendous harm and will cost us potentially far more in terms of lives and loss of life years, which also, you know, have huge implications for the economy. And so when I sort of step back and think about, like, you know, how do we spend our dollars around sort of substance use, is really sort of looking at, you know, where are the areas that we can perhaps get the biggest, you know, ROI on what we're doing. But it's never sort of a question of should we spend the money or not. It's that, you know, all of these lives to me, you know, are important to be thinking about and trying to address. And then just sort of following up on this, you know, this idea of sort of potentially for herd immunity, of, you know, not believing that there is some sort of a limit above which we shouldn't spend money, is that there's a lot of risks to that. And there's no scientific evidence to support the idea that exposing, you know, less vulnerable people will ultimately provide enough protection for more vulnerable people. There's just not an evidence to support that. And I think it risks doing a lot of harm to both the human toll, you know, across the whole population, but then especially within healthcare, which has already experienced a lot of fatigue and trauma. And I think it risks putting so much pressure on an already burdened healthcare system and staff who experience, you know, again, sort of this trauma and this fatigue and even death, you know, among their colleagues. And so when I sort of step back and think about sort of the, you know, the economics of it, I think that they are real and we need to be talking about them, but not that there's some sort of finite cap above which we should not be thinking about spending money.
Cynthia, I'm going to go to you on the same topic and add in a question from Alex Neely, who's from the health justice class. And as Dr. Hom was talking about, the resources really that the government's putting here, and as it deals with our health system and what the government will provide for, it is, you know, universal health care has been a topic that has come up. And Alex Neely asked, would the pandemic have turned out differently if we had had universal health care in our country? So from your vantage point, do you think that there would have been any difference if we had those kind of resources up front, or were we sort of destined to play out this way largely?
I think that what we fund certainly shows our priorities. And I think that had we did something better a long time ago, we wouldn't be in the situation we're in now. Think about my work with the homeless. And I know in my county, you know, we declared homelessness a public health emergency in 2015. We still have 11,000 people on the street every night. And those are the people who are hit hard by whatever, this time it's COVID, whatever's out there on the street. We have people who are dying of exposure. So we say that this is a public health emergency, but we fund services to help our homeless. We don't provide services to get them inside for any significant amount of time. We give shelters and money and say enough funding to say you're open 8 hours a day or 6 hours a day. So for these 16 hours, you have to be outside. So I think that we have to sort of get in alignment about if we're going to make these big declarations, we have to put our money where our mouth is. And I think that maybe if we had something like universal healthcare, then more people would have gotten a lot more services. Then all of a sudden we hit, you know, a pandemic, and now no one can get any service, and people are dying at alarming rates because we haven't invested in their health, just their general health and wellness. What Dr. Aronson was talking about before this even happened. We haven't valued their health, and our funding hasn't valued their health. So now we're in a place where we've got to try to make up ground. So yeah, I do think that it would have made a big difference, but also funding health and wellness before this even came about.
You know, right now it feels like we're like putting the plane together as we're trying to take off. Tomás, are we going to make the changes? Are we capable of making those changes in the prioritizing of our dollars?
Yeah.
As they apply to this?
Well, I'm never a big fan of calamitous funding, which is pretty much what we're in the process of right now, right? You know, invest a number of tremendous amount of dollars during the times of crisis, right? When this probably could have in many ways been addressed had we had the focus on prevention and really a holistic approach, you know. And the question of universal healthcare, I think, is a complicated one because when we're talking about when we're talking about health disparities, we have to understand what are the barriers, both structural and perceived, right? And I think we underestimate and don't include in the dialogue the importance of perceived barriers, particularly within communities of color. So it's not just an issue of you build it and they will come, by no stretch. We can certainly invest in funds to build health centers, right, in every community. And we certainly could invest in a new universal healthcare system that provides, national healthcare for every individual in this country. That does not mean that those communities who are most in need of it are actually going to seek those services. Because we have a legacy of racism in medicine. Tuskegee resonates profoundly through the African-American community, even decades later. Every immigrant has in some way confronted racism when confronting the healthcare system, and that informs safety, and that informs trust. And many of the patients that I work with have an inherent and very deep-rooted mistrust of the healthcare system, particularly the Western healthcare system, for good reason, because it has failed them on multiple levels, and because they see the advances of technology and the tremendous opportunities and resources which exist there that are inaccessible to them, simply by nature often of the zip code on which they reside, or whether or not what type of insurance they may or may not have. So, the issue of access is a complicated one, and it goes deep, and it deals with human nature. So I hesitate when I say more dollars will change that, because we have to deal with the human complexities, right, of why people choose or choose not to seek healthcare. And there is a reason why alternative practice is $1 billion industry, right? Because people do believe that there are different ways to heal. And Western healthcare, does not necessarily address that appropriately. So, but I do remain hopeful in other ways.
I like it. We'll keep the hopeful lens. We are getting some questions in the chat here, and we got a couple questions actually just about healthcare workers. So I'd like to go around to everyone here. Let's start. I think Dr. Aronson's up next, and it's interesting because Dr. Aronson, you're in the hospital right now, and you're wearing a mask. And we've got a question from Krista Bosco, an alum, saying, "I'm curious for all of you on this call who are frontline providers. How are you doing? And how are you going to continue when we are not doing what we can do to protect you and your colleagues? What are the long-term implications of asking our frontline providers to be expendable to the economy, or simply at the politicization of masks?" So, Dr. Aronson, it's about you guys out there. I mean, how are you coping?
Oof. I'm not sure I've ever been so tired in my life. It's been like a 7-month sprint, and I am the class of 81, so you can do the math on that one. It's exhausting, it's 60, 70-hour weeks. I and a couple of my colleagues started working with the Department of Public Health. This is not really supported in our division, so we are doing that over and above our full-time jobs, but there was no one in the San Francisco Department of Public Health that had any understanding of older people. The people on the team assigned to it, there was a guy from transport, somebody from refugee children, somebody, literally, and we're still doing presentations to the leaders, and they're making decisions about facilities, and then you actually give them facts and they're shocked, and we're 7 months in. So this feels like an absolute moral necessity to me, and I'm willing to be tired, but it's kind of ironic being the aging person, because clearly I'm having accelerated aging. I sit on my rear end too much. I go from Teams to WebEx to Zoom to this, that, and the other. I work easily 12 hours a day. I am very obedient, so I don't go out unless I need to. Thank God I have a dog, so I walk the dog. But like I've gained weight. I mean, I can barely, thank goodness I don't come to clinic that often, right? I can hardly get dressed. So at this point, I'm telling my patients, welcome to the hypocrisy clinic. Here's what you need to do for exercise. So it's tough. And I think we're also all realizing that there were the strategies to get through the early months. And now, as Dr. Fauci said recently, this may well go into 2022. And so we need to do a little something so that we survive that. I will say on the flip side, it's hugely gratifying, you know, to have any kind of work where you get up each day and you know you're at least trying to make a difference, and doing everything you can. And I think that's one of the things I talk about a lot with patients as they get older, particularly if they're retired. There's nothing better for health and a sense of well-being than purpose and finding meaning. And I think one of the great things about the health professions is that we get a lot of that. You know, we don't always succeed, but we do feel like we're always trying, and that feels really good.
Cindy, how are you and your colleagues doing?
I am exhausted. I second that emotion. And I'm not even providing direct care anymore. I haven't practiced in a couple of years, but I have a building of 65, 75 providers who need me to be here, who need me to be positive, need me to be energized because they're doing work. And a lot of them are worried about their kids who are at home. While they're here providing care, my 13-year-old's at home alone right now, and he's not having school success remotely. And I'm trying to juggle that part of it too. So, I mean, it's a blessing to have someone go, and I enjoy this work. I did all the training to do this kind of work and to be present for people who need me the most. So that's where I get my energy and joy from. But yeah, it's exhausting. And I think I have longer days now than I did when I was actually practicing, with all the public health meetings and things that I have to attend to now, and all the decisions I have to make in the moment. We have to extend clinic this day, or we have to shut down clinic this day. So just trying to handle things daily.
So I saw Jeffrey and Tomás both nodding. So I think they both are tired and having long days, and we hope you're coping as well. You guys can work this in your answer into any of these next questions, but I do want to just move along to get some of the other questions that are coming through on the chat. And we do have, oh, there we go, head of school. No question here, just a lot of gratitude. And I express that as well to all of you guys. I mean, you're doing so much, and I guess we're all benefiting from your shared purpose that you have. So Dr. Hom, as you look at this, the episode that we're still in, what are the lessons? We have a couple questions here about like, how is the future going to be different? What have you learned from this for the other side? Lessons, the word tools comes in here from this experience that will actually create change. Have you had those moments, or is it just like nose to the grindstone?
You know, I think a lot of it has been nose to the grindstone, and again, I'm so appreciative of my other panelists here just for their comments and gratitude for their work, being on the front lines of this. I think we're still, so much of our work is still just sort of on the day to day. I don't know, we've had a full chance to sort of step back and appreciate where we are and what we need to do differently. But I will say that I think as a result of this pandemic, obviously it's not something that anyone would have wanted. But I think as a result of it, there is much more of an understanding in the public about what public health is, why it's important, what it could be in the future, where maybe it's broken down during this whole crisis, but also what it could be. I think so much of what's happened with public health is that a large amount of money comes in, it funds whatever the crisis is of the day, and then it starts to dwindle. It starts to taper off when things sort of calm down, when it's on the headlines, and then the next crisis comes up. But in that intervening time, a lot of sort of public health departments sort of have slowly been whittled away and funded at lower levels than they really could be and should be. So I think one of my takeaways, one of my hopes is that with this new appreciation for what public health is, and it's not just sort of public health, it's certainly the collaboration with our healthcare systems and our healthcare providers, with our social service organizations, with those who are helping folks who are unsheltered. It's thinking about what are the partnerships that we can have moving forward beyond this immediate crisis that can help us sustain and help us improve the way that we might respond to the next one. And I think Dr. Aronson's point just about the healthcare system is truly more of a medical care system, and sort of shifting away more from thinking about that, but incorporating how can we think about prevention? How can we think about community well-being beyond just sort of medical care and diagnoses and treatments? So I think one of my takeaways and sort of again hopes is just that as a result of all the partnerships that we've developed over these last 11 months, 9 months, that those will sustain themselves. And then I think my realization, as I sort of listened to everyone talk and thought about this, is as we move forward, just also recognizing the importance of leadership and how critical it is. I think especially sort of at a national level, that we do have sort of a uniform approach to thinking about sort of prevention, to thinking about communication, to thinking about mask wearing, things like that that really could make a difference as we look ahead to the next whatever the next crisis is, that we do have sort of much more uniform leadership from the top. So I think that really could change the trajectory of whatever crisis is before us.
Well, I want to thank all of you. It is 1 o'clock right now, which is the window that we had given you. And I think we know more than ever how important the work that you were doing is. So I want to, give you the opportunity to leave. If people can stay, there are more questions. Mariana Stark is going to jump on and moderate some of those because I've got to go do a show. But, just to second some of the comments in here and just gratitude for all the work that you were doing and for joining the conversation with our high school. I mean, and speaking to the high school students, because listening to everything you're saying, it really is incumbent on the next generation that's going to come along and help make a lot of these changes. So thank you all so much.
Jen, thank you so much. This is Mariana Stark. I'm the Director of Alumni Engagement and Giving at University High School, and I'm also a proud alumna, class of 1989. I'm thrilled with this panel. Thank you so much to everyone who's participated. Louise, Jeff, Cynthia, and Tomas. I know it's the middle of the business day and you're the busiest people we know, so we were gonna end promptly at 1. So thank you so much for participating, and thank you, Jen, for your incredible moderation. Wow, what a gift to have a professional journalist handle this. So thank you so much. For current parents, I want to remind you that the fall play is tonight, the second showing of the fall play, and your student can send you the Zoom link so you can watch that. And for alums who are tuning in, and actually everyone, please nominate for alumni honors. We honor members of our community every spring, and and Jeffrey Hom is one of our 2 recipients this year. So thank you all so much for coming. We will edit this video slightly and post the link later so you can share it with friends and see it again if you'd like. So thank you all for coming.